Hey there everyone, Tom here from MoveEd. Welcome to this presentation on acute knee injuries. This will form part of the pre-reading for our face-to-face courses. A quick disclaimer, this is not medical advice and the content of this presentation is targeted towards junior or early career clinicians who are working in the private musculoskeletal setting. All right, so to run through quickly what we're looking for when it comes to taking a history from an acute knee injury, I'm actually going to use an example of a chronic knee problem that might present to you in the clinic. So I like to use a pathoanatomic approach to diagnosis, where I have a think about the area that the person is complaining of pain or other symptoms, break it down into the longest list of potential differentials that I can, and then look to gather information that either confirms or refutes the potential differentials throughout that gathering of information on the subjective interview and then on the objective examination as well. So here, for example, I list out a big bunch of differentials for anterior knee pain. Now, if I apply my approach, we're now looking at a case of a 53-year-old female who was otherwise previously sedentary but has more recently joined a walking group. She has a 1-month history of anterior vague knee pain and is worse when going up slopes or stairs, and she has no other significant past medical history. Upon examination, the patellar facets are tender on palpation. So what we can see here is that instantly, based on that relatively limited amount of data that we've gathered, we can almost rule out a number of the differentials that are listed down below. And there's a strong hint that this problem might be patellofemoral joint pain, but I've kept a few other differentials rather on the list, and I would be working through various questions about the pattern of pain, etc., and then objective examination maneuvers to confirm or deny the differential diagnosis of patellofemoral joint pain. Now, when we're thinking about acute knee injuries, the key problems are listed here, and these are the things that you should feel confident in assessing and diagnosing as an early career clinician. It's not exhaustive, and some things are more common than others, but these are the key pathoanatomic diagnoses that I think you should be comfortable dealing with. So we have ACL, PCL, the medial and lateral collateral ligaments, and the meniscus will form a bulk of your injuries. There's patellar dislocations and fractures, and then less common patellar tendon ruptures are clinically important. Posterolateral corner injuries are often undiagnosed or missed, but also clinically important. And then various fractures throughout the knee, including the tibial plateau or the fibular head. When we're thinking about these common or relatively common injuries, it's good to be able to break them down into the mechanism of injury, the specific signs and symptoms that you might gather from the subjective examination, and then which special tests or objective examination findings are likely to help include or exclude that diagnosis. So you can pause this video here and have a look at the table, but to use the ACL for an example, the common mechanism of injury is a non-contact pivot shift type mechanism. In terms of signs and symptoms, which are relatively more specific to the ACL, you have a rapid onset of effusion, some instability associated with the acute injury, and then the sensation of a snap or pop. When it comes to special tests, the Lockman test can be used, and then there's also the anterior draw, pivot shift, and lever sign. The latter three in that cluster there, I don't find as clinically useful, but it's helpful to know how to complete all of them and know the relative specificity and sensitivity of each when you're trying to make a decision about a diagnosis. As mentioned, you can pause this video here to have a look through the remainder of the list of the key signs, symptoms, and special tests that you might use for each common knee injury. When it comes to the examination, we're going to be using a look, feel, move, and special test approach. And the key things I want you to be thinking about when you're going through the early phase of working with someone with an acute knee injury is, one, when you look at the knee, do you think there's an effusion or not? And you can confirm or deny on a sweep test. Really pay attention to how that person moves before you then jump into the special tests, which overall are not really that special and needed to be interpreted with some caution. That concludes this presentation. I'll see you there.